Theresa, what's the percentage of the people that you see that would ask for and receive extended services, like counseling and that sort of thing? Is it very high at all,
Well,
or other healthcare visits, or just that whole educational component you discussed?
at every visit, we give patients information, but we really try to meet patients where they're at, and we know that we're focusing on a syringe access program. So the main thing is to get them syringes, but we also give them, usually it's my card for family practice, because it's hard to find family practice providers that are open to these kind of patients. And then we're giving them information. They get booklets when they come. Every time they come, they get booklets. They get packets about counseling, about 12-step programs, about religious programs, fill in the blank programs. We're giving them a plethora of information every time. And we ask them if they want to talk about it. Most of them actually tell us no, but we say, okay, the information's in your bag. If you want to look at it, let us know if you change your mind. So we ask them that every time, but just realizing that we're meeting them where they're at. That's motivational interviewing. It doesn't really work to mandate programs. That's been proven that it doesn't work to mandate programs. So we have to just meet those patients where they're at and wait till they're in that cycle of change and they're ready for action.
She said, I'm just curious to just put out a question. It's kind of along this line. Nova had last week a program called Addiction, the Science of Addiction. I just was curious if anybody got to see that, and if so, what they thought of it. A significant amount of that show was actually filmed in West Virginia. So
It's on West Virginia Public Broadcasting.
It was on, well, I was in Florida when I watched it. It was on public TV across the United States, actually.
Yeah.
It was an excellent program, I thought, because it really kind of said all of the things we're trying to say tonight about the fact that we need to think about things as a disease model, and that MAT has a role in that, because there is so many anti-MAT people out there. Dr. Gupta, who's our state health officer, was actually on the program multiple times, as well as the researchers from WVU. It was really, my husband watched it with me. He doesn't know the science and doesn't, he's, sleeps with a doctor. He doesn't get all of that right. But so he felt like it really taught him a lot and made him think differently, because he has, lots of noise from other people that is somewhat negative sometimes. So he thought it was very valuable to him. I just was curious if anybody else had.
It's on their website. If you go to West Virginia Public Broadcasting and Google Nova, they save all of those, and it's posted. I haven't watched it yet, but I have it saved to watch. And yeah, there's a lot of stigma even with healthcare providers. I know a lot of healthcare providers, and I think it's because we went from having pill mills that were creating addiction to having Suboxone clinics that were capitalizing on the weakness of people that were trying to get clean. And people that were just cash pay. Anytime you're just cash pay, there's a problem there. Not accepting insurances, and it was done wrong, and they were just giving out tons of Suboxone, and then Suboxone started to be abused. It needs to be well regulated, but we're getting better at it, and it's going to be the future of treating addiction.
A lot of those were actually the same doctors that were running pill mills. All of a sudden became Suboxone doctors.
I have a question about that too, because I was treated with Suboxone. I was on it for 4 years, and now I've been successfully off of it since a year. June was a year. And I've seriously mixed feelings about it all, because that was a whole nother hurdle, to get through, and I had to be spiritually in a really good place to be able to do that and be successful, and it was very difficult, but these doctors, they're really not supposed to be keeping people on that stuff that long, are they?
Well, that's actually a myth. Everybody's different.
Yeah.
Some people might be able to come off Suboxone or buprenorphine or whatever drug they're on. They might be able to come off of it after, a year, 18 months, 2 years. For other people, all of their triggers are still there. And they still have, have you ever heard of the ACE score, the ACEs score for children? So there's a test that you can give to kids, and you can very highly predict whether or not they will use substances when they're older. And for people that fall really high in that score, they're gonna struggle their whole lives. So they may need medication-assisted treatment their whole lives because they still have all of these underlying things that haven't been taken care of. So if we think of it as a disease model, I don't take my diabetics off of insulin after a year and expect them to get better. So some patients may need medication-assisted treatment for longer periods, 4, 5, 10, 15 years, maybe a lifetime. But that's okay because we're decreasing crime, we're decreasing recidivism, we're making this a gainfully employed person that can be a husband or a wife or a parent. And we're controlling it as a medication. It's a chronic disease that we need to treat chronically. So some people will be able to come off, but we just can't blanketly apply that to everybody.
I think you might get more acceptance of that once the injectables and the implants become more widely used. There'll be less diversion.
Less diversion. It needs to be well regulated, and we've not done a good job of it so far, so it's gotten such a bad rap.
Well, I think it also has unfair, because it's so easily abused and used, and, you know, they prescribe you 10 times the amount that, well, I might be exaggerating, but they might prescribe you 5 times the amount that you actually need because there is a ceiling dose and, you know, all that. That in the recovery community, it's really frowned upon, you know, people who, now me personally, I feel like, you know, just like you were saying, I have not had addictive behaviors for over 5 years now. You know, I have not been in active addiction for over 5 years based on, you know, the way I live my life, my choices, my priorities. So I personally feel as though, you know, when I talk about it, I would say I've been clean for 5 years, you know, and I've been off Suboxone for 1. You know, to me, that's how
I agree.
That's how it goes. And, you know, I just wish that we could get that better, you know, so that people aren't able to abuse it, so that it's more, so that more people can say what I feel, you know what I mean, and mean it, and other people look at that and say yes, you know.
There's a podcast by Dr. Jaffe, and he is a former methamphetamine addict that is a physician now, and he talks about medication-assisted treatment, and he talks about abstinence, and he's like, only 10% of the people avail themselves of any program, whether it's a religious program or a non-religious program or a 12-step program or fill-in-the-blank program. Only 10% of users actually avail themselves of any of these programs. So if only 10% of people are buying this medicine or taking this medicine, that's a pretty hard pill to swallow. So we need to change our medicine. So we need to change what we're thinking. And one part of what he talks about is, do we really expect abstinence? Has abstinence worked ever on anything before? So sometimes with drug users, we're not ever gonna get abstinence. So medication-assisted treatment is one form of not getting abstinence, but still maintaining that patient as a functioning human being. And then sometimes it's like allowing somebody that had previous addiction to drink alcohol. Lots of people who had substance use disorders with heroin or with pills can drink alcohol fine. But there's a lot of people that are like, you can't have any addictive substance because you have an addictive behavior or an addictive personality. Typically, addictive personalities are genetics anyway. But we just need to get away from that thinking that you have to have total abstinence to be a decent human being. This is a chronic disease. We need to treat it like a disease. And we need to realize that people are gonna be in different places with it.
Do you have any statistics regarding the harm reduction program here in Upshur County? As how long has it been?
We've met 3 times now. So it's the second Thursday of every month, and it's been there 3 times now.
And how many people have been to it?
The first time that we were there was 1, and then the other 2 times there were 9. And it's mostly word of mouth. It's not, you can't really advertise a harm reduction program in a paper because the people that need to use it aren't going to get the paper. So one thing that we do is we use Facebook, and you can Google it. It's the LIGHT program, capital LIGHT program, and then word of mouth. So we're seeing more people starting to come, and we're seeing different people coming.
So it's too early now to say if it's actually affected any kind of overdose rate
Well, as far as overdose rate, I can tell you between January of 2017 and July of 2017, Upshur County EMS used 79 Narcan doses. So now that doesn't mean that there were 79 overdoses, because the EMS will give a Narcan dose if you're unresponsive. So you could be unresponsive for like a diabetic coma. But I know that they've used 79 doses in that 6-month period, was the last data that I have there.
And, too early really to tell if it's had any effect on, Hep C or anything like that.
We've not diagnosed any Hep C's, which is good. I have Hep C patients in my practice, so I can tell you we have Hep C. When I've been at every harm reduction program, we've not had anybody test positive, so that's good, because then we can institute harm reduction, give them clean needles, and hopefully they'll never test positive. And then we can save $80,000 per person for the hepatitis C treatment.
Do you have any concerns that, I understand that even though you're not getting 100% harm reduction, but if you're giving needles to one person, do you have any concern that they're sharing those with their friends, and that you're only doing like a week of
I do have
harm reduction?
concerns, and we hope to increase the harm reduction program and to bring that van more often once we start building more patients. And we do let patients come pick up for their friends. We do, because some people, you know, we've had one guy that's been there videotaping patients as they're leaving the clinic. That's a deterrent to coming to avail yourself of this program. So Matt's been really great about helping us with that particular problem. But I want them to share needles. I want them to spread the word. I want them to bring everybody to this program. I want people to feel comfortable. One of my problems with the harm reduction program that we have currently at Upshur County is the Mylan Puskar van. Mylan Puskar is who's helping us with this.
That was my next question.
They come from Morgantown, and they bring a van, but they park this unmarked white van in the back of the health department, and then they later leave and go to the Y at Walkersville. I want patients to be able to walk in through the front door of the health department and sit down and have a seat and be able to come back like a regular patient and get their needles. Because we're stigmatizing this by making them come into the back of a white van. To me, that's no different than telling a black person in the 1950s to use a separate door or a separate water fountain. We've got to stop stigmatizing this, and we're doing it as healthcare providers. But we're doing it to not step on toes in the community. So there need to be changes, but it starts with talking about it as a health issue instead of a criminal justice issue or instead of shame.
Do you ever see that being a role of the primary care physician?
I do, and I'm actually going to be taking the waiver course so that I can prescribe medication-assisted treatment. I'll be taking that in December, and I hope to begin prescribing in family practice in the summer of 2019. Because right now, the closest person that prescribes medication-assisted treatment that I'm aware of is Dr. Solomon, and he's in Bridgeport, and our patients can't always get there.
Not only the MAP, but the needle exchange.
You know, I'm not sure about that, because there's some cost associated with that. And right now, the health department got a grant from the Palatine Foundation of Buchanan for $3,000 for those needles. And then, other than that, it's been Mylan Puskar that's been donating those supplies. So there's a cost associated with it, and there's a public health mandate. The Bureau of Public Health has told the public health departments that they need to do some kind of harm reduction. So I see it really being the domain of public health.
Theresa, I don't think I'd want to go through a meeting like this. It's a little different topic besides harm reduction, but when you talk about alternatives, the subject of cannabis has not come up, and I just wanted to hear what your opinion was as a treatment, looking at that in the future. Where do you, from what you know right now, what do you see its role?
I think there are a lot of studies that mostly come out of places that have done it well, like California. And it used to be called the gateway to drugs, now it's being called the gateway off of drugs. So cannabis therapy is way safer than what we've already prescribed: oxycodone, Percocet, Lortab, hydrocodone, fentanyl. It's much safer than all of those. There's never been an overdose death from marijuana. So it is a safe alternative to pain. It's also being used to bridge people away from drugs, and I see that it might be used in the future. I know in 2019, I think it's July of 2019, it's going to be legalized in West Virginia. I have concerns with how it was legalized. Instead of personal grow, it's going to be manufactured by Big Pharma. So I'm not necessarily a fan of that, but I think that it's going to have a role in bridging people off of things like oxycodone and heroin, other opiates. Any other questions or comments? I hope to come back another time and do some medication-assisted treatment stuff, talk a little bit more about that. Do you guys have any other interests and things that you'd like to hear about?
Well, I think I would like to hear your impressions or your observations or your studies about different types of recovery centers and what is available. For instance, what's available in West Virginia, and what kind of recovery program would you recommend that you know of that people could go to?
Yeah,
Within a 100-mile radius.
Within a 100-mile radius. Chestnut Ridge, I have a friend, Dilip Chandran. He's a psychiatrist, and I actually invited him to speak at my nurse practitioner residency about a week ago. And they are building a 90-bed, I believe, facility at Chestnut Ridge for substance use disorder. And they're doing some great things. They have something called the COPE model. And it's just a multitude of opioid-assisted treatments. It's a combination of many opioid-assisted treatments, and it's meeting people where they're at, and they use a lot of medication-assisted treatment, and they do a lot of harm reduction, and a lot of counseling, group counseling, individual counseling, and I think that's gonna be the best thing that West Virginia has done in a while.
Well, what I meant is that I would like to hear a presentation. I mean, it's pretty obvious for any family member who's ever been involved in that process that it's a very trying, tense situation that doesn't have a very clear path to follow. And so you're kind of just on your own, just doing the best you can. And so to have some information out about it, kind of give some way to certify or give you clear choices on the kind of. I mean, they can do that to a certain extent, but I guess it would be interesting to hear from the professional more about what other options are available in West Virginia, and within a 200-mile radius.
Even with all of my resources and connections, it's hard to get people placed. It's hard to find a bed. I'm hoping that this new facility will lighten that up a little bit, so that we'll have somewhere to place people, but it's hard.
Will that be
So
for
you think-
adults only?
No, I don't think that's just gonna be adults only.
So you think, like, maybe that would be a good topic for here? If I had somebody from like First Choice Health Systems who runs the 844 Help for West Virginia line come up? Because that's what they do, is they, Bureau of Behavioral Health and Health Facilities tried to give all of us access so that I could pull up a list and see where an empty bed was. And we're all supposed to report into it every day, and I'm not sure what happened. All I know is that it's not there anymore. But they can see in real time where beds are available at different types of facilities. So if somebody can call that and get a referral, they'll connect them to non-emergency medical or transportation to get them there if that's needed.
Yeah, I think that I would be interested in more just at going that next level, not only what's available, but just the choices of like any kind of a methodology that center's gonna have. They're definitely not all the same.
Right, like there's Teen Challenge, which is, Teen Challenge is a spiritual program, but it's you go there, you stay there, but it's not medication, it's Christ-centered, that's very
The
different.
other thing about the West Virginia number is when we called there, we got two places. One was like in Louisiana, one was in California. It wasn't.
Really?
Yeah, and they never said, there's nothing available in West Virginia. They never said that. They just like, here are the beds that are open. And we spent hours and hours on our own researching and found lots of other beds that were closer than that didn't appear to be on their list.
Well, that's interesting.
That's actually, a service that someone, I mean, if you could develop a good reputation.
I'll check with them, because they shouldn't,
The call for West Virginia? I'm wondering if you got switched over to the national line now.
yeah,
Because the
because
West Virginia
that's,
line, people don't even have beds outside of West Virginia. They have no idea what's outside of West Virginia.
there's actually, now you can actually pull up some 800 numbers that's what they are, basically patient brokers.
Yeah.
And that's where they'll stick down a plane in Florida. There was
No,
844 help.
no. We spent, I mean, I can't tell you how many phone calls to different
Huh.
hospitals. And in many cases, if you had your own health insurance, I'm sorry, we're only taking people that are on,
But the call West Virginia number was in
Really?
Elkins, right? Isn't
No.
that where they're
Now it's
located?
out of Charleston.
Maybe it was a West Virginia call, people that we were talking to.
Because we use the line
there.
every week.
I've heard of people that have had some negative experiences.
Well, you're
Not that
about-
many, but I've never heard anybody say that
You're-
You
before.
can't call in on the patient. The patient has to talk.
I know, but you have those resources. I'm saying as a person outside of that,
It's the
who's
same
just
resource.
looking on the outside, looking in,
It's the same
that
resource we have.
didn't,
It's no different.
it wasn't available.
I think that we need to make it more available to, like parole officers and the police. I know in other parts of the state, when they pick somebody up that's been, addicted or that they use Narcan on, they have immediate placement for them, and we don't have that around here. But I've had the same experience. I've called that number, or a number that I thought was local, and then got a bed in Florida. And they told me that my insurance would pay 80%. And I said, 80% of what? And they said, well, we can't tell you of what. Because it's just like being admitted to a hospital. We don't know how much it's gonna cost. Well, if I'm paying 20% of $100,000, I'd like to know that up front. So, I've had that same experience. Even with all of my resources as a family nurse practitioner and studying this for 3 years, I had trouble getting placement for people. So there are barriers. I'm really hoping that Chestnut Ridge opening this facility
Is
up
it male
changes
and
that.
female?
What's that?
Is it gonna be male and female?
It's gonna be male and female, adults and pediatric. The baby was good for the whole
He
thing.
was. Good. He was.
Amazing.
All right.
Thank you.
No other questions?
Thank you very much.